Part 4. This is such a good lecture. I found this information fascinating when I stumbled into it. So what are these algorithms? Let's shift gears for a little bit. Let's think like the test writers and figure out where they come up with the information that they're testing us on. When you're in the clinic, you should be thinking down an algorithm. That is, you start with the chief complaint and you end up with a diagnosis. The challenge in questions is to build the algorithm from the bottom up. Let's figure out what this means. So, lacking any better terms, algorithms are equivalent to flowcharts, are equivalent to schematics for the purpose of this lecture. Here's an example of a flowchart we've all seen for hyponatremia. Back in the late 90s, Faculty of Medicine at the University of Calgary actually started teaching students from a flowchart or schematic-based curriculum. They even put all of their findings of this teaching method and its effectiveness into a research paper seen below. What they developed from this was the Calgary Black Book. This is a hundreds of pages long PDF of all sorts of different algorithms that look like this. This is the example of abdominal pain. So you start at the top. Obviously, you have this acute abdominal pain, and you work your way down this chart and figure out what the diagnosis might be. The intention early on was that students would figure this out on their own. What they found by teaching this way was that students were not discovering these schemes as expected. And for many diagnoses, we all come up with our own little flowcharts of how you've diagnosed based on a chief complaint. But a lot of students weren't figuring that out, or they weren't figuring it out fast enough. What they found was it was better to be explicit up front about the existence of these schematics and teach the information in that format. So let's put this to use. We have a 34-year-old female that presents with abdominal pain for 12 hours. Okay? So if we break down abdominal pain, we start out, we have a diffuse side to this chart with many diagnoses under it. We also have a localized portion with all the relevant diagnoses under that. So based on whether or not you've isolated this pain to be diffuse versus localized in this patient, your diagnoses can fall into these two categories. Now so far, all we know about Our Lady is that she has acute abdominal pain. There are 41 diagnoses listed here. That's 41 diagnoses that you've got to sit there and think about and load into your brain. What these diagrams lack is specificity among the final detailed groups of diagnoses. Let's take a deeper dive into the lower quadrant pain and break some of these diagnoses down and see what it is we actually need to know to separate these diagnoses apart. This is my own format. Here we are, we're in the lower quadrants. The first thing we need to do is decide whether this is a peritonitis or a non-peritonitic pain. Once we've decided that, we break these diagnoses down a little bit differently. As you can see, for the peritonitic pains, there are 7 diagnoses. Based on their chart, there's not a great way to differentiate these with any one specific question. So what we have to do in our minds is break all of these down in a little bit of a different way. I took this bottom section of what they had categorized and redid it in my own little way. So here I proposed the question of asking about location after knowing the peritonitic pain. If the pain is not in the left lower quadrant, I can rule out diverticulitis. If the pain is not in the right lower quadrant, I can rule out appendicitis. If the pain is inguinal or umbilical, here are some of my options. Maybe the pain from appendicitis just hasn't moved inferiorly yet. Maybe I have the presence of a mass and it's very tender. It starts to rule in incarcerated hernia. And then here are these non-specific locations. They could be both sides. They could be unilateral. They could be bilateral. This is just another lens to break down these diagnoses. You can break down diagnoses by anything that sets them apart. So let's go back and take a look at our 34-year-old female and see what's going on with her. Let's continue from the top down and see how convoluted it remains. She had loose stool after eating last week, no constipation. She vomited. She's nauseated. Pain is a 6 out of 10 in her lower abdomen. Does not radiate. Past medical history insignificant, though she does have a bulge in her midline abdomen. She takes Tylenol for occasional headaches. LNP was 2 weeks ago. Not sexually active for 3 years. Physical exam, she voluntarily guards her abdomen. Increased pain in the right lower quadrant. Which of the following is the most likely diagnosis? I have my suspicions, but I don't know what the answer choices are yet, so I can't really pick anything. Alright, so now that I see these answer choices, I can start to rule some things in and rule some things out. But instead, let's take a look at these diagnoses and see what's different between them all in the context of a flowchart. What I'm going to do is take the flowchart that I have built here on the right and refine it to only contain the diagnoses of what's on the left. What we're left with is a very simplified version of our flowchart. Analyzing this flowchart allows me to come up with a specific set of questions to separate all of these diagnoses from one another with very objective questions. The lower two diagnoses, I want to know right versus left side. Does she have nausea or vomiting? Does she have a fever? And what's her last menstrual period? And what's her sexual activity? If I can answer these questions, I can differentiate between all of these. Now, I already happen to know that her pain is in the lower quadrant, right? And cholecystitis is an upper quadrant pain. So it's already moving extremely far down my list, and I'm probably going to cross it off. So here are the questions that I want to answer when I read this stim, if I can, if they give the information. Highlighted now are the answers to some of these questions. She's nauseated, she vomited, LMP was 2 weeks ago, not sexually active, right lower quadrant. Guarding rigidity, yes, it seems peritoneal to me. It's in the right lower quadrant. She has nausea and vomiting. This is really starting to sound like appendicitis to me. And in fact, appendicitis is the answer here. So in hindsight, when I'm reading a stim, I see these signs and symptoms like nausea, vomiting, time frames such as 12 hours. These are defining points of algorithms that take me towards one diagnosis and away from another. It's critical that you begin to understand that so that you can objectively rule things in and rule things out. So your job as a test writer is to change the answer of this question. So let's change it to ectopic pregnancy. How do we do that? We just need to change this given information. Last menstrual period was 2 weeks ago. She's not been sexually active for 3 years. Instead, let's say her last menstrual period was 6 weeks ago, and let's redact the sexual activity altogether. Now I'm not able to rule out ectopic pregnancy, and while it still could possibly be appendicitis, now I'm much more concerned that it is an ectopic pregnancy, based on the same flowchart. Nothing else changed. So we fade the red text to black. Now we have the same stim, the same patient, same pain. We have a different history, which led us into a different portion of the flowchart. Our algorithm yields us a new answer possibility, and one that is more likely in this situation. You'll notice she's got this bulge in her midline abdomen. Obviously, we could have gone the hernia route, but that's not even an answer choice. So your task is to reframe the questions in your own flowchart, in your own way, from the bottom to the top. This isolates the information that you need to know and helps you figure out what the question writer is really asking you in the first place. Next, let's talk about getting questions wrong, breaking them down, and how to learn from that.